Welcome at the talk show at TEDxMaastricht, the future of healthcare. We have some amazing guests, I might say. For instance, the person next to me, he was seriously ill, he almost died, found his own treatment, found his own health information, and here he is, alive and kicking. Dave de Bronkart. Dave, welcome.
Thank you.
How should I call you? Mr. de Bronkart?
No, E-Patient Dave.
E-Patient Dave.
Empowered, engaged, equipped, enabled, educated.
Okay.
The modern patient.
It's all about E. Thank you. And you're going to comment on what our other guests are telling about innovation, about the future of healthcare.
Okay.
Yeah? So you're on all the time. Well, we have switches on the other places. We have here Ronnie Zeiger from Google. Welcome. You used to be Dr. Google.
Sure.
Yeah? Chief Health Strategist.
Yes, until about a month ago.
A month ago, you left.
I did.
That raises the question, why did you leave Google?
You know, it was a wonderful, amazing 6 years of learning and accomplishing some important things. And now it's time to do something new.
Okay, and what is that? Where can we find you today?
Today you can find me sitting at this wonderful table with you.
Yeah. Mm-hmm.
And tomorrow I'm starting a new company called Impatient Science. And there's nothing yet publicly available about it.
Why not?
Things take time to grow and hatch, and we'll be sharing more soon.
Okay, but that's interesting. Because you're an advocate of publicly sharing information, aren't you?
That's a great point.
Yeah.
And
So how are you going to deal with that then?
so I spoke a lot earlier in my talk about the ideas that I think are most important to me and our path forward. Mm-hmm. And that should give you a very good sense of the kind of work that I'll be doing moving forward.
Okay. Impatient. We have to be impatient. We have to be a bit patient.
Well, we are impatient.
Mm-hmm.
And those of us that are most impatient, I think, need to stand up taller and a little bit louder to collaborate with those of us that might not feel the impatience quite as strongly.
Okay. What did you exactly do at Google? Because that's what your past was the last 5-6 years. You worked there.
Yeah.
What did you do and what did you achieve?
So at Google, I worked on a variety of health projects, ranging from really data analytics projects like Google Flu Trends, health records projects like Google Health, search projects like Symptom Search, and some of them were successful and some of them were not, and that's certainly what we should expect from attempts at innovation.
Yeah. Can you say something about the success factors or the fail factors? Why were projects
Sure.
successful or
Well,
not?
I think whenever you build a product, you do your best to understand what problem you're trying to solve and whose problem it is. And you offer an initial solution. And you expect to get it wrong because people are very complicated, appropriately so. And you iterate from there. Sometimes you find that you're close to a solution and you iterate in a certain direction. Sometimes you find that you're very far off and you start something new. Mm-hmm. I think that Flu Trends is a beautiful example of something that worked surprisingly well.
How did it work? What is it?
So Flu Trends is one of my favorite projects that I've been involved with. And basically the idea was, and this was not my idea, a couple of colleagues said, you know, I wonder if we could figure out how much influenza there is in different parts of the country and different parts of the world by analyzing the way people are searching on Google. And several of us, myself included, said, I don't think so. But we tried anyway, and turns out they were right, with some very interesting statistical analysis. You can figure out which people are asking questions that are related to the way people are getting sick with flu. And when you look at that data in aggregate, it matches very nicely with the data from the CDC, the Centers for Disease Control. And in fact, it comes out about a week or two earlier because we get all our data in real time and analyze it overnight, and the CDC has a much harder job of talking to a bunch of hospitals and laboratories to collect the data.
So you can trace epidemics like that?
We can trace influenza.
Influenza.
We've tried to generalize it, made it work for dengue fever, and then we've built a more general tool called Google Correlate, which allows anyone to take data that they would like to learn about and put it into the system and see what patterns come out in terms of search. It doesn't work for everything.
Okay, so and they're still working on that to make it broader?
This is still an active project,
Okay.
yes.
Okay. You're a medical doctor as well,
I am.
and you're still in practice.
I see patients every other week. I spend a day in clinic, and it's for very selfish reasons. It reminds me why I do everything else that I do, and it keeps me very grounded. I think especially in the world of modern technology, which is moving very quickly, it's easy to get distracted and to fall in love with things that are shiny
Gadgets.
and beautiful and
Yeah.
gadgets, which I use many of, and forget that the reason that we're doing all of this is because real people have very real problems.
Okay. Coming back to your new company, the name. There's no
Inpatient science.
impatient science.
Yeah.
I'm very impatient. Could you just tip one tip?
Yes, because you asked so nicely.
Yeah.
So I think that more of us are understanding that the patient perspective, the patient expertise, needs to become part of the discussion between the patient and the doctor. That this is no longer a downhill discussion, but this is a partnership. And one of the next steps, one of the additional steps, which is what we'll be working on, is connecting patients to the researchers that are inventing the next generation of treatments. These patients have a lot of very important ideas and experiences, and for the most part, these two groups are not collaborating.
Okay, and you're going to change that, try to change that?
I hope so.
Or you have a tool to change it?
We're working on some.
You're working on it. And when do you present it?
As soon as it's ready.
When will it be?
I don't know.
Okay. We come back to you in a minute.
Okay.
Yeah? At the other side of the table, there's Andre Piso. He's CEO Health, Microsoft Europe. Is that correct?
I wish.
You wish? Oh.
I'm director of
Director
health.
of Health. A CEO is not a director, I understand.
No, I think our CEO is called Steve Ballmer. I think,
Okay.
yeah, it's a
No.
little bit higher above my pay
Okay.
grade, I think.
Yeah. And what's your function? What are you doing with Microsoft and Health? How does it work?
So my role in Microsoft is business
Yeah.
development for new health technology. And this is what we bring to the market together with our partners. So I do a lot of research in the market. Look what markets at the moment are in the most of need of new innovation. And together with our team, we try to bring the best that we can to that market and make it a success.
So, can you give an example? For instance, Health Vault, is that something you're bringing to the market for the best?
Absolutely. So HealthVault is already there in the market in certain countries. It has been rolled out, and now we're exploring the opportunity in other countries across Europe. For the Netherlands, for example, it takes quite a lot of time because you have a lot of different angles that you have to look at before you bring a product to the market. Yes, it is indeed a consumer product.
But can you explain what a consumer can do with Health Vault? What it means to the consumer?
Sure. HealthVault is a platform, an open platform, in which you can store your data in and you can connect your apps to it. So you will always have it available in your pocket or on your PC, wherever you are, any place, anywhere.
So it's a personal health record you have always with you?
Yes, and it's a self-management environment, something that's very much spot on the things that we as a consumer would like to have today, such as Facebook, as an Amazon. HealthVault is a logical next step, only then more to the health consumers.
And who puts the information into this health record?
First of all, yourself, and secondly, you have the opportunity to integrate HealthVault with medical systems that are being used by your caregiver, or all kind of electronic devices that you can use today in your fitness and wellness exercises, for example. And if they come along with a small app, you can connect that to your HealthVault, and it will automatically also be synchronized with your HealthVault.
Okay, and how do the providers cooperate? Do they?
So what we see, for example, so in the Netherlands, because we didn't roll out health vaults yet, we have to step to those countries where we do. For example, the NHS, National Health Service in the UK, they see a big provider using health vaults, exactly doing that, but it's going step by step. So as you know, there are a lot of different systems being used across the healthcare industry, from a general practitioner area to a more physician area, and they have all their own little systems. So,
And then stops on technology, different technology, or not?
I'm sorry?
Is that where is the barrier to share it?
No. It's
Because
not to say, so the technology is not a barrier. It's more like that once you have the connectivity available, it's going to be on the board for a hospital, for example, to decide to what extent of information they wish to cooperate. And I think there's a lot of cultural change needed within the care society, I can say. We were talking about that earlier today, Dave. That also doctors need to change and willing to share the information if you need that as a consumer, as a patient.
Okay. Monique Philippens, I'd like to introduce you. You are a CEO, I read here,
Director
of
also.
healthcare, also
We have
director.
another- yeah, sorry for
Wow.
that.
Well, you are on a very good level. Anyway, at KPN, and KPN is a partner of the Future of Health of TEDxMaastricht 2012. Why did you choose for this partnership? What does it mean to you and your company?
Yeah, if you look at the newspaper, you see a lot of negative publicity about healthcare, about problems of cost, problems of lackage of people. And we think that it's better to talk about the positive side of what we can do about it. And I think TEDx is a wonderful day with a lot of inspiring talks, with a lot of emotional talks, and also people with very good ideas. And we like to sponsor that, so that as much as people can hear these stories.
Okay, but the involvement of KPN with health, that's for some people it's a mystery, because KPN people think it's telecommunication or telephone systems. What's the connection with health?
Well, KPN and telecom is about connecting people. And if you look in the healthcare business, we have to connect the consumer part with the healthcare part. If we look at what we do within KPN, then we try to give people more quality of life by improving their the independence, by putting things in the home so that they can stay longer at home independently, but also to increase the mobility by apps on mobile phones or by telemedicine services. So there's a lot to do in that area.
So there you connect also with the healthcare providers to work differently?
Yes, it's always about connection between patients or clients or consumers, call it as you want to call, with healthcare professionals.
Okay. If you have to give an A or a B or a C, how far have we developed in the Netherlands this cooperation?
Between healthcare professionals and patients?
Information and sharing information and...
Well, that's a difficult question, because if you look at the medical information and the medicines, then we are quite far ahead. If you look how good our medical information, like medicines, is stored by pharmacists, then it's quite good. But on other areas, I think we have still a lot to improve.
Okay. Yeah. The benefits for the patients?
More quality of life, better quality of healthcare, and better communication.
Okay. Whose talk are you looking forward today?
Oh, that's a difficult one.
it's an impressive lineup.
Yeah,
so
I think
you
the whole
don't have
day,
one favorite?
No, I just sit and listen and try to instead.
Thank you very much. André, there was something is interesting that Google stops with some health activities, and you introduce Health Vault. So what's the difference between the two experiences? Perhaps you can explain that to us.
What, Health Vault versus Google Health, for example, would you refer to? So first of all, I cannot talk about Google Health, but I do know
Only
about
can?
Health Vault. Yeah,
Yeah.
well, I don't know.
Okay.
He just left.
Okay.
Maybe
Okay.
Dave can. So I think
come back to you then.
You know, it's. I just read a book of Willem Vermeend, one of our former politicians, and What he said, if you look at the economic change that's happening right now, and the uses of internet, it's increasing rapidly. So today you have about 2 billion people using the internet. And within 3 years, the expectation is that it might be 3 billion people worldwide. So the speed of using internet technology is very fast. Now, if you look at time to market of new concepts, also in health, and if you also look then at the difference of behavior of both consumers and care providers, that is changing rapidly. So when Google came to the market a couple of years ago, and you compare it to today, and you look at the users and the readiness of the user in using that technology, something already is shifting and changing. If you look at the device manufacturers that are now willing to connect with health platforms such as Healthful, the amount of devices is huge. It has exploded. So
Isn't that
so that's the answer on your question. I mean, why? Because you can also say, why not? I mean,
that's why you stay and why you go on.
Well, this is why we stay. Well, first of all, we didn't do a worldwide rollout as Google did. We started in America, so we choose a different strategy, slowly rolling it out, because we also recognize that you need to work together with care providers, and legislation per country differences, and the usage of internet per country differences, and so this is what you do thorough research too. Yeah. So I think it's time is a big element in the answer of the question you're asking.
Thank you. I'm going over to Ronnie to touch base with Google. What happens there? I want to thank you for your being here, sharing your ideas and your experiences in the talk show. Thank you. Ronnie, is it the right impression that Google makes a sort of U-turn in health?
So first a caveat, I don't work for Google anymore.
No.
So I'll give you my impressions as a civilian. I think it's actually relatively straightforward. As we touched on earlier, building products have many elements to it. Some of them we understand, and some of them are magic. So we looked at a set of problems, and we built something at the time that we were working on a personal health record, and the empirical data showed that we got it wrong. And whether that's because we were asking the wrong question or because we provided the wrong answer is a debate. That's a very fun debate to have. But we chose to focus on other things. So for example, the last several years at Google, I focused most of my time on health search. One of my personal motivations is that as a physician, I really enjoy seeing patients, but one of the reasons I've had a very unusual career is because of observations like as many people ask questions in the Google search box about health as ask questions of all doctors on the planet on a given day. And that's a huge opportunity. Making that incrementally better can have really big impact.
And that's still going on.
Absolutely. And that's, impact drives me, and certainly impact is what drives Google.
In fact, you say there is no U-turn.
There is no U-turn? Well, I'd say we're making small turns all the time.
Okay.
And it should be no other way.
Okay, thank you. I go to e-patient Dave because he said he gave the impression that he knows more about Google than we do.
I said
Dave.
I could talk about it.
Oh, you
so.
can? Yeah, of course. We can talk about anything.
Of course.
What is this technology and this sort of revolution in information sharing mean for the position of the patient?
Well, the ability to create value, this is my view. I'm the first one to say I knew nothing about medicine until 5 years ago this winter. I was diagnosed as almost dead, and then I became very interested, all of a sudden, the way we heard this morning. Like now, as Ronnie described it, a micro expert in a particular subject. And interestingly, the most valuable information I got came from the patient community that was created by his partner in this new venture. And I learned also that very often where we fall short of what human knowledge could bring to a medical crisis, it's because the information that was out there, what some new researcher is working on, has not connected yet with doctors. Now,
I remember you're saying, give me my damn data.
Sure. Well, that was about
So-
my medical record.
Yeah. Okay.
Yes, there were many mistakes in my medical
There were
record.
mistakes, but doctors were not willing to share them with you as patient.
Well, at my hospital, they
Yeah.
pretty much were.
Oh, they did.
But I had never looked into them to see that there were so many mistakes there.
Okay.
You know, the possibility, that's what I think is the overall challenge that we have in improving healthcare is to take families in need and smart, highly trained medical professionals and connect them with the information and resources and skills that they need to solve problems.
So, and
You know.
do you need the Googles and the Microsofts and the KPNs of this world to...
Oh, absolutely, absolutely. I mean, where do we go, you know, when you want to find something? Like, what did I do? As soon as I had my diagnosis, I went home and I Googled kidney cancer,
So,
you know? So the great opportunity is to, you know, use information, use somebody's medical records to be able to find, you know, that the rule is that after new research has been completed, it's 2 to 5 years before it's published in a medical journal.
takes too long. You didn't have that time.
My median survival was 24 weeks
Okay.
at diagnosis.
Okay.
So, and I know a woman, for instance, who found a researcher, the sort that Ronnie was describing, who was working on a new breast cancer project. It never would have been published in a journal, but she brought his project to her oncologist, and they concocted a solution. She lived another 18 months because of that. And that was using internet technology and patient communities to connect the doctor and the needy patient with new information.
Okay. I just got a Twitter question from Ted Doman. I got it on paper, by the way. What should we do first to change healthcare? We keep that one, but first change the technology or change the mentality?
Yes,
Dave,
both.
both.
Absolutely.
Okay.
Well, you know, if you wait for the technology before you change the mentality, it'll take forever, because until the mentality
What would you
changes,
do about
people
that?
will say, why do we need the technology?
Okay, but what could you do to change the mentality?
I go around telling people about what's possible
Okay.
with
Like
real,
stages
true
like this
patient stories.
Okay. Thank you. We'll come back to you in
Okay.
a bit. There are two new guests at our table. They are Renata Bak and Frank Schalke. Renata Bak is a patient who still lives where he supposedly was dying. Frank Schalke is director of eHelp. First go to Frank Schalke. Welcome. You're the founder of the eHelp Foundation. What does it mean? What does it do?
We help organizations from healthcare, mental health care, youth care, social work in implementing online counseling and e-health. So, well, as you know, internet is used very much in a lot of branches, but I think especially for healthcare, it's a wonderful tool. People are so willing to share their problems with peers, with doctors, problems on a social level or psychological level. For example, people who are
Is it
addicted.
even easier than face-to-face contact?
For a lot of people, it's
Can you
easier
give
to have contact by mail, by chat, by bulletin board than seeing their doctor. They don't even go to a mental health hospital.
Okay, can you give an example of that?
Yeah, what we see with alcohol addiction, people, they don't want that their boss knows they have a problem. They don't sometimes even want that their wife or husband knows. So they go and start with, for example, Google, and they find information, and then they find out it's not only that I drink a lot, but I can't handle it. I have to do a therapy, and they find out that there are more and more therapies by internet.
So you have online programs for that to
Yes.
help the people. What are the results of that?
Well, what we see is that a different kind of patients are doing the online counseling. For example, with alcohol abuse, you see that it are not the older, lower educated men, but it are the younger, higher educated women. They want a different type of therapy. It's the therapies we have now are already 10, 20, 30, 40 years old. The times are changing. They want new ways. They want to do it in the evening so they can go to work. It's ease of use. It's low threshold.
Okay, so technology there is not a problem.
No, it's about mentality.
It's about mentality.
course,
So
yes.
that's the question from Ted Doman.
Yes.
You want to change the mentality.
Yes, the technology is there already for 10 years, and it's still such a small part of the whole healthcare that is using internet. So it's the mentality of the institutions, the mentality of the policy.
You wrote a book on online care. Is there a part of working on this mentality also in your book?
Well, it's not big enough. The next edition will be a lot. The chapter about the mentality will be bigger. There are still, for example, when you go to educations, schools, there are still a lot of therapists who finish their education. They have never heard of e-health, of online counseling. But it's already 10, 15 years in the Netherlands.
Yeah, but you still have a long way to go then.
Yes, of course.
Okay.
Yes, we fight on it.
Okay, thank you for the moment. René Tabak. René is an ex-patient, as we can say, an empowered one. He was listed to receive a transplant heart, but budget ran out for the year, and he had to go to Germany for a new heart. And on January 5th, 2012, he spoke at TEDx at Radboud University in Nijmegen, and his talk was called "Don't Look at Me, but See Me. Don't hear me, but listen to me."
Yeah, well, sort of, yeah. That's
Yeah?
what I said, yeah.
That's what, and what did you really mean with that?
What I meant by it was that you have to see the person behind the patient or behind the disease. That's what I meant by it.
Okay. And you didn't have that experience?
Sometimes I wonder when you come into a doctor's room whether he, what he sees coming in. You know, is it the patient, is it a disease, or is it the person? And well, in my case, I had very good experiences with my doctor at the Radboud University Medical Center. But I've also had my general practitioner, for instance. When I came to visit him for small illnesses or anything, he always start typing on his computer. He didn't look at me, he didn't talk to me, he listened to me and he started typing on his computer. There was hardly any interaction.
You didn't feel like having contact with this person?
I didn't feel like having contact. And after he made a few mistakes, I dismissed him and I looked for another doctor.
Okay, you did have that choice to change.
Yeah, I had that choice, fortunately. Yeah.
Okay, and then this heart, your heart didn't function.
No, I had heart
Anymore?
failure,
Yeah, heart failure.
which was diagnosed in 2005. And in 2008, my condition was so deteriorated that I could barely survive. It was a matter of weeks. And then I needed an LVAD, which is a heart pump. It's an assist device for your heart. And I went to Utrecht here in Holland. I was examined, and they say, "Okay, you're a patient that we can transplant. It's okay," but they didn't give me the heart device, and that was because the budget had ran out before, and it was sort of
for a period of time.
Yeah, it was say July when I went there, and they said, "Well, we ran out of budget. They'll come back after January 1st," and I didn't have that time.
No.
So we talked with our physician, and she got engaged in our problem, and she really helped me a great deal by using her contacts abroad in Belgium and Germany. And finally, I ended up in Germany, where I got immediately a device, and they really didn't understand why I couldn't get it in Holland, because they said, it's a matter of money, or is the insurance not paying because we got the devices. No, but it doesn't here. So.
Okay, that's a wonder. I wonder if Ronnie Zeiger could have been this general practitioner that was. You work in a primary care center, don't you?
In an urgent care center, yes.
You listen very well to patients and then type everything in the computer?
This is a fabulous question.
Yeah.
So we're still new at this, and many
about the attitude of the doctor. That's
well, so it's still a new idea for many of us doctors that we're now told, please treat your patients with respect, and by the way, please also enter all of the information into this computer. And you still have as many patients as you had before, And good luck if you're going to go home at the same time. And so the answers are not clear. There's some small things that many of us now understand, which is, for example, if I'm seeing you in the clinic, one important thing is for both of us to sit where we can both see each other and we can both see the computer. So it's not me at the computer or me at you, but we're actually sharing the experience. What I tend to do is actually it takes me a little bit more time because I spend most of the time just talking to the patient and looking him in the eye. I have the ability to do that and still get all of my work done, and it's partly because of the setting that I practice in, and it's not always practical. This is a big issue, and part of the answer is making the software better, because today the software is in its infancy, and for the most part it's terrible. So it requires more of my attention than it should, which requires me to take some attention away from the patient. But some of it is mentality, where we need to understand that this software is not just for me. It's part of our discussion.
Yeah, and it changes your attitude and your relation?
It can.
On the spot,
it can. So it can hurt the relationship. It can also help the relationship. Certainly for any physicians in your audience, one thing that I strongly encourage them to do, which is a little scary the first time perhaps, do Google searches with your patients, or whatever search engine you like. I don't care. You know, this is something that they're going to do when they leave your office. This is something that you're going to do when they leave your office.
And you can support them and you can
and
do it together.
You know, here, let's actually get a preview of what you're going to see at home.
So there's a partnership between the doctor and the patient.
And it also gives the patient permission to next time ask questions about what they found online with no embarrassment.
Okay. For now, thank you very much, Ronnie Zeiger. I'm very impatient to hear what your company is going to do and to achieve. Thank you for your contribution.
Pleasure.
Okay. We go back to René Tabak. There was a quest, and it went abroad.
Yes.
And in Germany, you found this new heart.
Yeah.
But it's quite sort of shocking that you had to do this.
I really felt let down by Dutch healthcare. Yeah. It's not about expertise in Utrecht, but the way the system is operating at the moment with a very high pressure on cost, controlling of cost. That's caused the problem that I had with Utrecht, that they didn't have any money.
How can a system say that there is no future for you? It's a sort of indifference in the system?
No, it's also maybe in this case with the LAVD is probably, I don't know what the reason was, because these devices are made by dozens and easy to get. Another thing is when you need a transplant heart, which is much more difficult to get, especially in Holland, because of our donor system we have. Not everyone here is a donor unless you agree to be. And that's why we first looked at Belgium, where it's just the other way around.
Yeah.
And, but it's certainly a donor problem that we don't have enough donors for organs, whether it's a kidney or a heart or a liver or whatever, or lungs. We don't have enough donors. So they have to be very specific in what people are accepted as a receiver. And maybe that has something to do with it too.
You did your own quest. What can patients in general do to fight for their cause?
Well, I had we had great difficulties in finding funds for the operation in Germany. We contacted my insurance, and well, you get somebody from the help desk, and they know how to block you off. And then behind the help desk,
what's your experience?
Yeah,
they block me off.
Yeah,
okay.
Several times, and then behind the desk there's a doctor, and a doctor gets a report. And he either says yes or no, but he doesn't know the patient, he's never seen the patient, never heard of the patient, he only gets what's in his report. And my doctor at the Radboud tried to contact that doctor, and they were very angry about that she even tried that, because it was not usual to do that. And so eventually the insurance company gave in after a lot of phone calls, a lot of talks, and a lot of discussion, and they came up with the money that I could be helped in Germany. Okay. But it was a real fight. They had no contract with that hospital like they have with some other hospitals abroad. Okay. So you had to stand up for yourself real hard to get that.
Okay, I want to ask Dave, is this a unique experience, or is this what you see everywhere?
Well, certainly the American healthcare system is disgusting in how the great majority of it is just about people's revenue.
Okay, that's
You know,
a lot of René Tabak stories there.
I called my insurance company last fall about a bill, and to make a long story short that I wrote on my blog, they said, we don't know what you are being charged for.
So?
So I understand that when a company is organized to do a particular job, they try to find a way, they create policies to do it efficiently. So for instance, you have phone calls with questions about something, and you can't have the most expensive people in the company handling every call, so you create policies. But if the policies then prevent the right thing from being done, right? And if you don't allow the people who are in a position to make a good judgment to be involved.
That's the same with
Exactly, that's my
yeah.
point,
Yeah.
exactly. Then the company and the policies have become a disease that are not doing what they were intended to do.
Okay. Namely, what was the
Well,
core business?
Deliver care.
Deliver care.
Yes,
And
I
they
mean,
don't
I'm
do it.
sure
Yeah.
when the insurance company was created, nobody had the idea of preventing care.
No.
Although sometimes it looks that way
Yeah.
today.
Now, Vin Jain said something about that. Huh? No doctor is paid to keep people healthy.
Well, at least in some countries, I hear they are, but in the US, we have this huge problem with fee-for-service medicine.
Okay.
But there are some health systems where they are paid to actually keep.
Okay.
The-
But then the other side, because there are also patients who ask perhaps too much. And we saw an example with a new guest, Jeroen van Dillen, welcome, gynecologist at Radboud University Medical Center. And you had a talk this morning with a patient where there was, you had a lot of dilemmas. How far can you listen to her? You can listen to her, but go on reacting in a positive way to all what she wants, and she wants too much. That is, in fact, one of the messages. You could not be empathetic all the time.
Yes. There's the challenge.
Microphones.
My microphone is
Yeah,
now it's
okay.
working. Yes. I think doctors are in a continuous challenge where you want the patient. You want to treat the patient as you want to be treated yourself. That's what we stand for, this compassion charter. But in the same time, you need to make choices. You need to make decisions. Where do you draw the line? And that concerns all these issues I mentioned, but probably even more issues. And I named just a few.
Okay, and then the indifference that Mr. Tabak met, what is then it goes too far, isn't it?
The indifference that Mr. Tabak met is horrible. And the indifference, as far as I got the message, is not from the doctor, but from the system. And not even the medical system, but the insurance system. And that is something I think we have to fight together. And we have to strive for improvement in that.
Okay.
Yeah, but sometimes you also get indifference from a doctor. And maybe that's part of the fact that there used to be a huge gap between doctors and patients. Now, patients looking up to their doctors, and they're coming in and tell me what's wrong with me, and they follow doctor's orders.
And that's now the past,
And
isn't
that is changing, of course. That is changing. So I still think that patients are not always empathic to your problems, your emotions, the things you deal with. They are sick persons, they have their own interests, and they don't look beyond that. And so it needs time and a shift in culture to obtain that.
What could you do, then that's the last question for you, to change that?
What I need from my doctor, if I want to be sensitive to his problems, I need confidence. I have to have confidence in my doctor. And in order to get confidence, I have to be able to speak with my doctor on a human level, not just on a patient-doctor level, but a human level, a personal level. And if that's the case, then it's also possible for a doctor to convince me to take the right action and to to take my medicine in time, to follow his advice, etc.
Very clear. Thank you very much. Thank
Okay,
you very much,
you're
meneer Tabak. Frank Schalke, is that the mentality change that you want?
Yes.
Yeah.
You mean the compassion? Yes, but I think you can organize compassion on different ways. My specialty is the internet, and there are possibilities of organizing compassion not only by the doctor, but as well by peers, by volunteers, by family. And by organizing this compassion, it might be able to have a little bit less compassion from the doctor, but more from the other stakeholders, and maybe it's even cheaper and better in that way.
Okay, thank you very much also for your contribution. You want to react, Dave?
Yes, just very briefly on this. There's this widespread concern that if you let patients have whatever they want, they'll just spend forever. There are actually two different areas of research that counter that. First, there's SDM, shared decision making, and there's about 20 years of research that shows that when patients are well informed about the range of options, they choose less surgery and spending decreases. That's interesting. Then there's a fertility clinic, in vitro fertilization clinic. Jan Kramer, who is involved in this, is here. And they gave their entire patient community a wiki, an online discussion forum, and 6 months to come up with a list of the top 10 things they wanted.
Some people don't ask too much.
Well, and just the top two things they asked for was more treatment, but then the third thing was they wanted empathy, not just information. The fourth thing was they wanted separate waiting rooms for women who were pregnant and ones who weren't, and things like that.
And these wishes were met or not?
That was the agreement. The point is that what people want is not necessarily more spending. They want more care.
Okay, then we go back to Jeroen van Dillem, who said in his talk, I cannot be empathetic all the time. Did I hear that correct?
Yes. And of course, I mean,
That's what patients want, according to this survey.
Every doctor is a unique individual. And what I wanted to share is that I also have other duties, but a life outside the hospital. I am a person also, and I can be empathetic up to a certain point with a certain patient. Sometimes you have a click, and then you go a little bit beyond the level that you normally go to, sometimes a little bit less. Friday evening is different from Monday morning. I am a person as well. We as doctors need to be able to show that. And we step down from our throne, which is a good thing.
Yeah.
I think the role of the two persons, the doctor and the patient, are changing. And that the patient has a right to ask for that change. The doctor has a duty to do so. But the doctor also, I think, has a right to show that he is a person and he has certain beliefs and certain levels he can adjust to. And one doctor can do that differently than another.
Okay.
The dilemmas I have, the first thing I do is I go to my colleague and I ask him, I have this problem, how would you deal with this? And how do we deal with this together?
But then you have to communicate about it, to be open about it, which can be a problem also.
Yes.
But with a lot of colleagues.
And at a certain point you have to say, I can go up to here. And as far as empathy concerns, it depends also on your personal level. And if you deal with, for example, oncology patients every day, I can imagine, and I'm a gynecologist working with obstetrics. At a certain point, that most of the things I do are joyful, bringing a new life. But if you work with oncology patients, I can imagine that at a certain point you say, for now this is too much for me.
Okay.
I want to learn the patient, I want to know the person in front of me up to a certain level.
Okay.
You cannot be friends. Sometimes you need to have the role of the doctor.
I go over, thank you. I go over to Saskia Timmer from the company Changing Healthcare. And it says, well, are these the themes that you meet? You wrote a book on it, on e-health also. the themes about technology, about compassion, about empathy, about mentality. Are these themes that you're working on also?
Yes, I think these are the essential themes for healthcare as of tomorrow, I would say. Because what I see is that our healthcare system is choking. We are abusing it, and this will not last very long.
How are we abusing it?
Because we're not thinking about the right way of using it. Because if we use it today, it should be lasting for our children and the ones after it.
It's not sustainable, you say?
It's not sustainable, not in the way it's
Why not?
organized now.
Costs too much, brings too little?
Yeah, it's a healthcare system that's an old system, and I think we have new means, such as e-health, social media, and that can create new resources. But also, what's an important theme is also what you mentioned, it's empowerment, but both ways. We call it participation, and that's no longer voluntarily. You should have the discussion also with your patient about participation and how can you be an empowering doctor or healthcare professional, but how can the patient also be an empowered patient and a participating patient?
And how can he or she be empowered? What's the clue?
Well, I think the clue is start talking about it. For you, if you have the dilemma about, you say, well, I'm also a person, I can quite understand that. So I think the nice thing to do is to talk to your patient about what you expect. What you can do as of now, as of tomorrow, is start each consult or each contact you have with your patient and what do you want, or end it with what do you think of me as of an empowering healthcare professional? Do you have any suggestions for me? And the other way around, the healthcare professional can give suggestions to the patients. We have lots of modern means you can use to be empowered. Online information is an important tool, social media is an important tool, so we can help each other.
Okay, so, and you say the system is choking, so it seems to be acute.
Yes, I think it's acute.
What are we going to do today?
I think everybody should feel the sense of urgency, and everybody should act upon it. And what we tend to do is we tend to see the problems, and there are lots of problems, and we are focusing on government for them to fix the problems, and I think we can all add up. We can all start working on it. You can advise your patient in all kinds of applications, mobile apps you can use to monitor his own disease, you can guide your patient to good online information. These are all steps we can make.
Okay, thank you. Doesn't sound like rocket science.
No, it isn't.
It's no rocket science.
No, it's not about the technology. It's only about the right mindset.
Okay.
And the right mindset is an understanding for both of us, but also a shared responsibility for the healthcare system, but also for the patient.
Okay. Thank you, Saskia. The patient next to you at your right-hand side.
Not a patient.
The patient, the person, the guest, you're not a patient. Okay. Aren't we all patients?
Yes.
Yeah. He does believe in rocket science, I think. It's about a very important role of technology. Naveen Jain, welcome. Philanthropist, entrepreneur, and technology pioneer. And you are a CEO, aren't you?
Yes, I am.
Yes, finally. We've got a CEO of Moon Express. And the first company on this planet that has been founded on the moon. Explain that, please.
Well, actually, the company is not founded on the moon, but company is found to essentially be the first company to go to the moon and find the resources, the rare earth elements and helium-3 and bring them back to Earth to make life better for people on Earth.
So you going to put an office on the moon?
No, actually, we're going to send the robots to the moon because they don't complain too much. They work 24/7 and they don't need much empathy either.
So they can handle that.
They can handle that.
Okay, but why the moon? Saskia just told us it's no rocket science at all.
Yeah, so I think, if you're coming back and saying it's really not about going to the moon, it's really a frame of mind is that what you want to do with life. And he said if you want to go to the moon because there are things that you need from the moon to make life better on Earth, you can do it. So if you look at healthcare, as Saskia says, the problem is acute. But the way we are solving the problem is not ever we're going to get to the solution.
We're too slow, we're too less energetic?
Well, I think the problem really is that you're working on the edges. And the problem is the core of the system is broken. And you say you continue to work on the edges and hopefully you think the system is going to get better.
Explain that, please. The core of the system is broken. What is broken?
The core is broken because the model is a fee-for-service model. A doctor only gets paid when he sees you when you are sick.
That's what you said this morning. Doctor has no incentive to keep you well.
That's right. So I think that fundamentally we have to align the interest of a patient, a doctor, and the person who's paying for it, which is the insurance company. And if you put them together and come up with a system, and we have to completely overhaul the system that's based on how to keep you well. And our healthcare system actually, as I said, is really not a healthcare system. It's really a disease care system because nobody's talking about maintaining health. All they're talking about is when you get sick, how to take care of you. And I think until we can fundamentally change the way the diagnosis is done and we start to use the fundamental technology to able to diagnose the problems using the microfluids, using the lab on the chip, that means you can bring, as opposed to using the experts, start to have the nurses or even the patient themselves become the CEO of their own health. They need to be monitoring every single day what's happening inside their body.
Okay. And it's about own responsibility for
right.
everybody. That's
Absolutely.
What you say? Yeah?
So you need to be monitoring yourself every day, and until you become the CEO of your own health, don't expect somebody else to take care of you.
Okay. You have to take care of yourself.
Or at least you have to have enough information and to have self-diagnosis tools that are in fact not based on intuition. Today, the doctor really uses the intuition to diagnose the problems. Think about it. In today's world, where the globalization and the Googleization of the world, you have plenty of information. There is plenty of technology from the lab on the chip to microfluids that exists today. You'll be able to diagnose the diseases much more precisely and be much more personalized. So just like everything else, it has to be personalized and it has to be adaptive not only to the patient, but it has to be accurate based on the science, not intuition.
Okay, thank you very much. We're going to finish in a couple of seconds this talk show. Thank you very much, Saskia Timmer, Naveen Jain, Jeroen van Dille. Patient Dave, Patient Dave,
Yes.
Which means empowered.
Engaged, equipped, enabled.
Is that what has to happen to persons and to the system?
Exactly. You know, we talk about participatory medicine. It's not just about listening more to patients. It requires more active patient engagement. A doctor wrote a blog post a couple years ago. He said, physicians are coaches, like Paul Levy on the football pitch. The patients are players. If the girls he talked about hadn't followed his advice, they would not have grown and developed. And we as patients need to get off the couch and do more.
Okay. Thank you very much.
Thank you.
Patient Dave.